Welcome to Mama Tusa, Conversations with a Midwife. I'm your host, Atusa Benji. A quick note before today's episode. This show talks about birth, life, death, and all the complexities in between. My goal is always to share stories that leave you feeling empowered, but please know that some topics may be challenging or deeply moving. Also, while I'm an experienced midwife, I'm not your midwife, and the information on this podcast is not intended to be medical advice. Please consult your healthcare provider when considering what is best for you as an individual. Now, without further ado, I hope you enjoy the show. Welcome to the Mama Tusa podcast.
Thank you so much.
It's so great to have you.
Thank
My
you.
guest today is Dr. Joseph Roofeh, who has become a beloved collaborative physician, and I'm so honored to work with you. Thank you for collaborating with us, midwives out here working in the community setting. I'm going to make you blush for a minute because I read your bio. You are trilingual, English, Spanish, Farsi. You are a member of the Menopause Society, the U.S. Women's Health Alliance. Of course, you're a super doc. And you practice over here in Beverly Hills, and you have privileges at Cedars-Sinai Medical Center. And you provide obstetrical care and gynecological care. And you attended the Israel Institute of Technology for your doctorate, and then went to Detroit Medical Center in Michigan. And I love this because it's just so on brand for you. While in training, he was one of the top residents in a class of 40 residents and was voted to be academic chief in his final year to create lessons plans for standardized tests and surgical curricula for the new residents. And patient-centered attentive care. That is you. That is so on brand for you. I'm so excited to have you on the podcast. Thanks for your time.
Thank you so much for having me.
How did you become chief of residence?
From when I first started, I always loved teaching. I loved having students. I loved getting them involved, getting them incorporated into the patient care. And year after year from the beginning, I was winning an Excellence in Teaching Award, not even just from the residency program, from the actual hospital. So I won it the first 3 years that I was in residency.
Wow.
And then fourth year, there's administrative chief and academic chief. And I wasn't planning to do either of them. It just wasn't. I didn't come to my attention. But the other residents in the program told me that I should probably pursue academic chief because I like making lesson plans. I like teaching the students. They're always getting involved. I was, doing little small lectures for them. So I got nominated, and it was through a vote. I ended up winning, and the role was essentially creating lesson plans for our didactics and what should be spoken about. I had to also get different speakers to come give the didactics. I ran journal clubs every month at different restaurants with different reps.
Journal club.
Yeah. We used to do that all the time. Every month we had a journal club.
Like you would read an article in a medical journal and then talk about it.
Yeah, I would assign 2 residents to read an article and discuss it, and the company that was sponsoring the journal club would also talk about their product as well. And then we'd have question and answers, and obviously
cool.
dinner. Yeah. And then our program was, we had a lot of GYN, so we were trying to get our program robotic certified for robotic surgeries, and we needed a robotic surgery surgical like a plan. Yeah, so I had to develop that. We had we made a plan with the attendings, and we made different courses for the first year, second years, third years, up until their 4th year, so they can get certified for robotic surgery.
Love that. I too love teaching.
Yeah.
I like to have like one foot in the classroom and one foot by the bedside.
It honestly just keeps you on your toes. You have to always stay up to date.
You have to stay on your toes, and I think there's a humility in learning also from your students, which I love. And I love watching their wheels turn and like something like come to fruition for them. It's so exciting. They're like, I got it. I remember when I was in midwifery school, and like learning cervical exams was so like, where is it? I don't know. I think that's it. Of course, that was like at the back of the vagina and nowhere near the cervix. I was like, I think she's 10. And it's like, took a while. But the first time I got it, I was like, oh my God, like I got it. Like it fundamentally, the knowledge clicked, and it's such a good feeling when your student learns something like that. So how much OB do you do, and how much GYN do you do?
In the beginning, I was a little more GYN heavy, just trying to get my name out there. OB is a little bit more, it's tougher to get patients, but now after a few years, I'm almost 50-50.
Nice.
Yeah, so I do half OB, half GYN, which was my goal. That's the reason I came into OBGYN was I didn't want to subspecialize and give up one aspect of the specialty. So I'm 50-50.
You're
which
50-50.
is my
Maybe
goal.
when you're 80, you'll
Yeah,
tone it
maybe
down
90.
a little. We'll see. Maybe 90. And why, I want to know what propels you to support midwives in the community. Why do you do it? It's not easy.
A lot of it came from my training in my medical school in Israel. We did a 8 or 9 week OBGYN rotation. And in that rotation, the hospitals in Israel, they actually have midwives doing all the uncomplicated deliveries.
Yep,
and
as they should.
And there was a doctor covering 3 or 4 rooms for any complication or any C-section.
Yep.
And I saw the camaraderie, the collaboration, how it worked so well for that hospital. I do know midwifery support and even doula support does decrease the C-section rates.
Yes, it does.
So it is something that I think is important and a great collaboration to have. Midwives have their knowledge base, their specialty. They know what they're doing, and doctors have their own set of skills and they know what they're doing.
Correct.
When you combine two really good skill sets, it only enhances the care. So I think it's a way to provide the patients with the best possible care without compromising anything.
Well, thank you for doing it, because it's not easy to get a call from your collaborating midwife in the middle of the night that says, hey, can you come in? We need this, that, and the other. And you always show up. And what I love about the care that you provide is that once you enter the room, you don't kick the midwife out of the picture. You still incorporate her, which I think the clients really, really appreciate and is a testament to your humility. So thank you for doing that. I was thinking earlier about what we were going to talk about, and you and I went back and forth about it, and we came up with the topic of exercise. And I was like, oh, I'm going to talk about exercise. Okay, what are we going to talk about? But then later when I slept on it, I was like, there's so many ways we could go with this. Tell me why exercise came to mind for you.
Exercise came to mind for me because I think it's one of the most important things someone can do throughout their pregnancy to help optimize their pregnancy, their postpartum, and the lifestyle of their future kids. I think with exercise comes good diet, usually naturally. You just want to take care of yourself. You just want to
eat better, right?
Yeah. If you don't exercise, you tend to, okay, I'll eat this ice cream, I'll eat that ice cream. But when you start exercising, you get motivated to make a meal plan, proper diet.
For sure.
So it just changes just overall lifestyle. It changes mood. And, postpartum depression, 1 in 4 to 1 in 7 people experience either blues or depression. Very, very common. And we do know regular exercise throughout pregnancy and the postpartum period definitely does decrease that from happening, which increases bonding, breastfeeding. And it's something that I think is very important. And a lot of women that I talked to, when I first was promoting exercise, just to gain an understanding of what my patients knew and didn't know, I would ask, what kind of exercise do you think is okay in pregnancy?
Yeah.
A lot of them would say, just a 20-minute walk, like walking the dog a few times a day.
Yeah.
What I want them to understand, you could do more vigorous exercise, moderate intensity. It could be yoga. It could be, modified Pilates. It could be, more strenuous exercise than just walking. And I didn't want them to think that they can't do anything more.
Going back for a second, can you just differentiate, what is the difference between baby blues and postpartum depression?
Baby blues is when it's the first 2 weeks after delivery. Sometimes I'm not so strict with the guidelines. It could be 3 weeks, 4 weeks, but it doesn't severely impact your relationship with your baby or your husband, and you're still able to feel happiness and go about your day. With depression, even postpartum anxiety, but mostly postpartum depression, you're not able to take care of your child the way you feel you want to or are supposed to. You aren't socializing. You're trying to stay away from friends, family, it severely impacts your quality of life. And with the blues, you're still able to find enjoyment. With depression, you're having a very difficult time finding any enjoyment.
And then, of course, there's anxiety and obsessive compulsive and things like that. Talk to me about modifications. So what would be an example of a modification in yoga or in Pilates?
So with pregnancy, progesterone naturally causes a little bit of laxity inside of some of your joints.
Yeah.
It allows your hips to stretch, and that causes the ligament pain. But when you're trying to do things like squatting or things that require a lot of flexibility, you have a higher chance of injuring yourself due to the extreme laxity. So you just have to modify some of the different positions you're doing in yoga, so you're not stretching your joints too much, because naturally you can stretch it a little more.
Right, so you go over.
Yeah, without realizing, and it can cause a real strain on your ligaments. Also, modifying the workout so you're not in a position where you could potentially fall and hit your stomach on the floor. For instance, if you're doing a 45-minute class or like Orange Theory and they're doing push-ups, I tell my patients try not to do the push-ups because you're trying to keep up with them, but if your elbows give out or your muscles give out, you're going to fall on your belly instead of falling on your butt or your back, which is less harmful.
Right. And also there's a difference between someone who's been doing Orange Theory for a long time before their pregnancy. I don't recommend starting Orange Theory the first time when you're 3 months pregnant.
I agree with that.
And most people I actually don't like Orange Theory ever, but that's
I don't get any money from Orange Theory, I promise you that.
Yeah. Sorry, Orange
Barry's
Theory.
boot camp.
Your rowing machine just does not work for me. But is there some truth in telling clients, don't really start anything new? Keep doing what you've been doing, maybe increase the intensity. But if you haven't done ballroom dancing or Orange Theory or hot Pilates, don't start the first time in your pregnancy.
You can potentially start something new in pregnancy because there's some women who are just not working out at all.
Right.
I don't want them just walking.
Right.
So I want them to get
more.
into something.
Right.
I would say if you're going to you can start something new, but don't jump right into Pilates, even new Pilates. First, if you haven't been working out, maybe walk a little bit more, go on a light jog, a little bit more intense jog. Honestly, water sports are the best. You're buoyant. You're not going to fall. Yeah. You're exercising all your muscles. Your thermal regulation is good. Your body's getting hot, but you're in a colder environment.
Yeah.
So it's honestly the best way to go about getting into exercise. And once you get your endurance up, your muscle strength up, then you can start potentially incorporating new things like yoga or Pilates. But I understand what you're saying. Something new like that, you have a higher chance of falling, injury,
stumbling, things like that. What do you think about wearing a heart rate monitor? First of all, what's the range and how do you feel about the monitor?
Up to 130s, 140s is okay. The heart rate monitor would be good so you don't go, for two reasons actually, so you don't go above and so you're working out hard enough that it's getting up there.
Oh, interesting.
Some of the societies say the way that how you can perceive what good intensity is or not is if you can have a conversation with someone without heavily breathing, then you're at lower intensity workout. If you're not able to fully converse with someone or you can't sing, then you're at an intensity. That you're at an intensity that's probably good.
I never sang at Orange Theory, that's for sure.
They never gave you the mic?
I just cried most of the time. Not my jam. So do you think that it causes because one of my arguments that we are over complicating everything with technology when it comes to pregnancy. And do you think having someone wear a monitor is it's kind of like having a baby monitor right next to your ear or at the table when you're at dinner?
Yeah.
Because you have to see every movement that the baby is making. Do you think that parameter is enough, that if you're able to talk, then you can make it a little harder, but then when you're really unable to talk and you're out of breath, then you're over the line? Personally,
I don't like the excess technology. I'm not a fan of, I think less is more sometimes, and listening to your body is better than telling you what the heart rate monitor says.
Totally.
Even the Aura rings, I wore it for a bit and I would wake up and it would say, poor sleep, don't work out today. I'm like, I feel great. I'm going to work out,
right?
Absolutely
not. Yeah.
So I definitely, it's a good adjunct, but I don't advise my patients to wear anything like that. I just tell them to get to a point where you're working out and you're breathing heavily, but you're not feeling like you're going to pass out, faint. For people who work out regularly, they know they have their their barometer of what's too much and what's not. For someone that's starting out new, I would tell them to go slowly into it, and I think the being able to talk or converse with someone is a good way to determine.
It's a good parameter. Talk to me about hot sports, hot yoga, hot Pilates, hot tubs, hot saunas.
Hot. I don't recommend any of those, especially in the first trimester.
Why?
In the first trimester, extreme temperatures above 103, 104 can increase chance of neural tube defects.
Defect.
Yeah, so you want
And miscarriage, right?
and it does a little bit miscarriage, yeah. So you'd want to try and refrain from any of those hotter activities. Second trimester, third trimester, when all the organs are already developed, and there's less of a chance of that. We do know that hotter environments makes it a little bit more difficult to thermoregulate your body, and it can increase dehydration. It can increase more injuries with passing out, and it's not recommended to fully avoid them. You can do them for like a 5-10 minute period, but not those 30-45 minute hot yoga classes or hot Pilates.
Okay, and getting in a hot tub.
I usually advise against.
Also, I think that people feel crappy, and that's a good way to know it's not a good idea to do it. I remember this woman talking about having miscarriage after miscarriage, and they just didn't know what was going on with her, and they started investigating a little bit. She was hitting the gym and then hitting the hot tub every single day at her local spa, and finally she was the one that figured it out. She was like, I wonder if it's the hot tub. And stopped, and then proceeded to have, normal pregnancy and gestation. But it's so easily missed. What is the danger of a baby's heart rate staying up high for too long? Because mom gets hot and then baby's heart rate goes up, right?
Actually, sometimes mom gets hot and baby's heart rate goes down.
Goes down. Okay, tell me more.
So they've done some research studies, and what happens sometimes, same with working out, your body temperature gets hot. Going to the hot tub, your body temperature gets hot. The blood, when you're exercising and your body temperature is getting hot, is actually getting redirected mostly to your muscles. So naturally, when the blood's getting redirected to your muscles, less of it's getting into the placenta. So we do know that we see a little bit of a dip, because they've done studies where moms are working out and they have the monitor on. They see a little dip in the heart rate initially, and then they see a little rise in the heart rate with the baby, and the rise is a compensatory to get the baby more blood. To get oxygen back to the baby.
That's so interesting, because we do intermittent monitoring. And so we probably often miss that little going down before the going up, because I know that if that water, that sometimes I'm like, I'm going to take a shower. And I go in and it's like steamy, and I'm like, let's get out. And then the fetal heart rate's like 180. I'm like, all right, now we got to, got too hot. So probably we missed the going down part, which is, natural part of intermittent monitoring. I'm going to throw out some exercises. Tell me yes or no. Yeah.
Okay.
Swimming.
Yes.
Horseback riding.
No.
Bicycle.
Stationary. Yes. Outside. No. Any trimester. Usually it's not recommended, but in the first trimester, the pubic bone is pretty well protecting the uterus. So I will allow it a little bit, but after that, I say stationary bike. Yes. Bike riding outside. No. Running? Yes.
Uphill walking?
Depends. If you're in high altitude, no. If you're in normal altitude, yes.
What's considered high?
Colorado, Denver. I don't know the exact feet that you shouldn't go up, but
okay, not Mount Kilimanjaro on your honeymoon pregnant.
No,
not so much. Yeah. What about like deep sea sports? Can you scuba dive in pregnancy?
No. The pressure is harmful to the baby.
What else is absolutely not recommended?
Contact sports, horseback riding, football, hockey, soccer. Tennis is okay, but you have to be careful. Quick stop and go can be hard on your joints and can cause injury.
Skiing,
snowboarding,
skateboarding
too. Skydiving is toss up for me.
Skydive. Well, that's altitude though.
I know. So the altitude, I recommend against it.
Yeah. And the parachute not opening.
Yeah, but chance of that is so rare.
So rare. I know. But still. And then what about pelvic floor issues? So, I mean, we know that a lot of people end up having pelvic floor issues, whether it was the pregnancy or it was a long push or it was heavy exercise. My parameter, and this was partly personal experience and clinical experience, is I don't love the dangling weights. I feel like when you're carrying a barbell and you're standing, you're putting a lot of pull down on that pelvic floor. And especially if you are one, pregnant, or B, postpartum.
Yeah.
The elasticity is going to cause some incontinence issues and some, bladder issues, things like that, which is why my pet peeve is the car seat.
Oh,
I think that car seat is the worst thing that was ever created for postpartum healing. It's great for the dad. It's great for if you have someone to help you. But for someone who's just given birth, we tell them not to carry anything heavier than the baby. And then you put the baby in a 10-pound car seat and now you're carrying 20 pounds.
20, 30 pounds, you're right.
Right?
I didn't even think about that, because I tell my patients no weight-bearing exercises in the first few weeks, especially if you have incontinence, because it's going to
Totally.
worsen it.
Totally.
Never tell them about the car seat.
And then we carry the car seat,
Yeah.
which dangles.
Yeah.
And so I remember my grandma, rest her soul, she's here somewhere. Grandma, she's over there. Whenever I went to her house with the car seat, she was like, "In bachه را از این تو درار بغلت بیار تو خونه من." She would say, take your kid out of
So
it
smart.
and put the baby on you
Yeah.
and come into my house. Don't bring the damn car seat. And I'd be like, "Oh, Grandma, you're so old fashioned." Everything she has ever said, Joe,
Has been right.
everything she's ever said has been
What
right.
if the baby was sleeping?
She didn't care. Oh, she didn't care about sleeping babies.
Oh, really?
Oh, no,
what,
she
really?
loved waking babies up to play with them, to make
No,
sure they were
for us,
breathing.
own daughter. If they're
She
sleeping,
was-
you don't say,
Oh,
well,
mine was the opposite.
you tiptoe around the house. You don't even brush your teeth because of brushing they made.
Oh, no. My grandma, rest her soul, had a little OCD component. And
Yeah.
so literally, like,
It's good.
like,
It's tough for
not
love.
OCD.
It's better.
She would just be like, she would literally wake us up like, Khubi.
Yeah. No,
Yes, not anymore.
For us, it's the own daughter is poor child. Don't bother them.
Don't
so-
go after it. Yeah,
Yeah.
poor baby. Yeah, that's so funny. Different families have different norms. If you like Mama Tusa, check out Actually Useful, a show about why the tech world is broken and what we can do to fix it. Each episode, hosts Ariel and AJ talk to some of the smartest people in tech who are trying to build a better internet. If you're angry at Uber for jacking up prices, can't believe Netflix kicked you off your ex's account, or don't understand why tech CEOs can act like shadow politicians, Actually Useful is the show for you. My favorite is their episode on AI. I learned a lot about the climate cost of ChatGPT and how this AI craze is more of a hype trend than a real advancement in tech. It's a big topic, so I appreciate the team for breaking it down for their listeners. Check it out every other Thursday, wherever you listen. I want to know why there is so little emphasis on exercise and nutrition from the OB model.
I don't think it's just lack of emphasis. We don't learn nutrition. We don't learn about in medical school or in residency. So it's very hard for us. We can learn about it, but we just haven't been trained, not our comfort zone to talk about so much. Same with exercise. We know the benefits of it, but we haven't been taught. We weren't taught so much in residency. We're not very well taught how to counsel.
I'm going to go further and say you're not taught very well in prevention.
Correct.
You're taught very well in
That's a good way to think about it. Yeah.
in pathology and how to fix it,
Yeah.
but not very good in how to
prevention.
prevent it. My client just said that one of her first trimesters, she was at the OB, and this is not to knock OBs. I love OBs. I work with OBs. Her particular experience was that she went to the OB and said, "I don't think I'm eating enough protein. Do you think I'm eating enough protein?" And the doctor was like, "You're eating enough protein. You're fine." And she was like, that struck me as a little weird. So then we started talking, and I had her do a diet diary. She was getting 30 grams a day.
That's all.
I was like, that's not enough protein. So I counsel for half of your body weight in grams. Would you agree?
Yeah. Protein is the building blocks for muscle, bones, pretty much needed for all bodily functions.
Every body function,
Yeah.
right? Every single thing
Yeah,
from your
you-
placenta to your hormones.
Yeah, you need all three categories: protein, fats, and carbs. That's why when patients come tell me that they're on keto or they're not eating any carbs, I'm like, I don't recommend excluding any
Right.
food group from your diet.
Yeah.
You should modify 40% protein, 40% good fats, and then 20% carbs, and half your body weight in protein, and that's like your benchmark.
What are you seeing in clients who are not exercising?
I notice the patients that tend to exercise regularly throughout pregnancy, their core strength is better, so their pushing efforts are usually much better,
Wow.
and their endurance is higher. So in primes or first pregnancies, when you know that the pushing may last longer, may last 2 hours, 3 hours, I less frequently see maternal exhaustion. They're tired. It's hard.
It's hard.
Not easy at all, but exhaustion to the point where they're almost about to give up from lack of energy. And I think the outcomes tend to be a little bit better in those women because less likely need a C-section from what I've seen.
Interesting. And is there such thing as too much exercise?
There is too much exercise detrimental. You want to make sure, one, if you're exercising to a point where you're losing weight consistently throughout the pregnancy, that's not good. You risk injury unless you're a professional elite athlete where you're on a very well regimented plan and you have doctors following you regularly and it's part of your profession, there is too much exercise that is not good. You shouldn't be exercising too much.
So it's taking away from the baby or it's taking away from the mother?
Both. Mom has to grow in order for baby to grow. Mom can't stay the same weight or even lose weight. 25 to 35 pounds in a normal weight individual is a healthy weight gain. That's what we want. With extreme exercise, again, during that exercise period, sometimes baby's not getting enough blood flow. Short-term exercise, we know it is good. But when you're doing it repetitively 2 or 3 times a day, every day, then it becomes detrimental.
So when we're looking at a woman of a normal body weight, we want her to gain about 25 to 35 pounds. Is there such thing as a person who constitutionally just doesn't gain a lot of weight in pregnancy, but the pregnancy is fine and the baby is a good weight?
Yeah, that can happen. I see it as well. As long as we know that the mom is nutritionally feeding, and she's not starving herself, we're not in some kind of famine. If the baby is growing well, then we know that the pregnancy overall is okay. And even though she's not gaining up to that 25 or 35 pounds, if it's 15 pounds or 20 pounds, it's okay.
It can be sufficient.
Yeah, because there are some women who have nausea throughout an entire pregnancy and they just can't eat the amount of calories that is recommended. And the amount of calories you need for your baby is not as much as you think. You're not really eating for 2.
Yeah. It's like 300 calories.
Yeah, 300 to 500 calories.
It's a bagel.
Yeah, exactly. And they'll take it from you if they need it.
Is that true? So that was the other thing I wanted to ask you. What is this? Is the baby a parasite?
To some extent. For instance, thyroid.
Right.
The baby takes mom's thyroid. That's why thyroid demand goes up a little bit.
Right.
So if you're hypothyroid, the baby's going to get some of that thyroid from you. If you don't have enough, it won't take enough, but it's still taking from you. That's why the demand goes up, because it's going to take more and more as it needs.
Right,
so
which is why it's so important to get proper care for hypothyroidism, especially in the first trimester, because the demand is so high.
Yeah.
And then when you look at blood sugar, that's fascinating too, that the baby's blood sugar goes up and then the baby urinates more and there's insulin resistance. Like the whole mechanism of gestational diabetes is kind of wild. Like when I read about it, I'm like, that's kind of crazy. Talk to me about clients with gestational diabetes. Where have you seen success with clients who are able to control it with diet and exercise? What kind of diet and how much exercise? And where have you seen it lead to insulin dependence and then ultimately needing to be induced or needing C-section?
With gestational diabetes, I've seen a lot of success in women who are motivated to watch their blood sugars and meet with a dietitian and follow the dietitian's plans. You can meet with the dietitian, but if you're cheating once or twice a day, you're going to have 1 or 2 abnormal values a day and you're checking it 4 times. So if you're having like 50% abnormal, that's high. So you have to be motivated to maintain your blood sugar. You need a plan. You could be motivated but not have a plan. So you need both motivation, plan, and support. I think if you have those 3 things and you stick to it, I've had a lot of patients with gestational diabetes not need any insulin or any medication, and those pregnancies do well. They don't need further monitoring. They don't need NSTs, non-stress tests. There's no risk of macrosomia, polyhydramnios, hypoglycemia during delivery. Water,
yeah. And things like that. And they go on to have normal, healthy deliveries with no need for induction.
Yeah, correct.
What is the cutoff for your 1-hour glucose screening?
I try and be moderate, so I use 135.
You're okay with 135. Yeah. Is there a strict parameter of 135 or 140?
It's based on a demographic. If you have you're in a demographic where there's a higher incidence or prevalence of diabetes, the cutoff you want to use is 130 because you want to be able to catch more people. Right. This is what the screening tool is for. Yeah. If you're working with a demographic that diabetes is much rarer, going to a cutoff of 140 is okay because you're more likely going to get more false positives if you do the 130 cutoff. So it depends on your demographic.
Interesting.
I hedged. So I did 135.
Yeah, I think 135. I think Kaiser is at 135 now. I know some people still use 140.
Yeah.
Depending on their demographic. So it's always an interesting conversation. And then there are clients who just decline the GTT, and then you're just watching the baby grow and symptoms and things like that. What about exercise and gestational diabetes?
One is very important to prevent gestational diabetes.
Why? What is the physiology of that?
Exercising creates insulin sensitivity, meaning when you exercise, your muscles become more sensitive to insulin and you're able to lower your blood sugar much easier.
You need less insulin to get the job done.
Correct.
Essentially.
Correct. You need less insulin to get the job done, and the job gets done better. Your blood sugars go down.
So then when you talk about insulin resistance, that means that you need way more insulin because the body is not so sensitized to it.
Yeah, because your organs all need glucose.
Right.
You have to get the glucose from your blood into the organs. If your organs, your muscles are not sensitive, they're not reacting to the insulin as well, they're not going to take the sugar from the blood, so it's circulating in the blood, which is not what you want.
And what are the dangers of gestational diabetes?
Consequences could be big baby, macroscopic baby, which has its own consequences.
Which is what? Why are people so afraid of big babies?
Big babies increase the chance of a shoulder dystocia during delivery, and it increases the chances of hypoglycemia after the baby's born, which can be very severe.
And that's because the baby has been maintaining high blood sugars because the mom has had high
Correct.
blood sugars. Then they essentially sort of need to detox from the sugar. So it's almost like a sugar withdrawal that it drops their blood sugar.
So what babies are doing when mom is hyperglycemic or has high blood sugar, that goes to the baby. So the baby's making its own insulin to lower its blood sugar. And when the baby's born, that insulin is still high. But the blood sugar is not being given to the baby from the mom.
So it's too much insulin for what it's intaking.
Exactly.
Which is a tiny little bit of colostrum.
Exactly. And not even that, it's even before the colostrum starts. It's right when they're born. In addition to the colostrum, but right when they're born, the baby's not getting any more of mom's sugar. And the insulin was already high, trying to compensate for the high sugar that the mom was
It's crazy.
giving.
It's like having an insulin pump on and getting IV insulin at the same time.
Exactly.
Like, it's just too much.
And then you just take away the IV sugar.
They're taking the IV sugar, yeah. And so what's the danger?
Of hypoglycemia. Can cause seizures, brain dysfunction. All your organs need sugar and glucose to maintain their function and energy at the cellular level.
Homeostasis,
and so your organs start to fail.
And does that happen quickly?
If the hypoglycemia is not treated within hours,
you could start
correct.
having a damaged baby.
Yeah.
So the remedy is a little bit of formula or a little bit of harvested colostrum or whatever you can to give.
And sugar.
Do you have a success story from a client who changed their lifestyle or the trajectory of their birth and delivery with exercise and the way they were eating?
I do. She hasn't delivered yet. The pregnancy is going much better. She came in, I forgot the exact numbers, but her blood pressure was high on the first initial visit. And her hemoglobin A1C was pretty high too. And then I spoke to her about both of those and I said, let's give it 2-3 weeks. I want you to change. I came up with a little bit of a diet plan, and for the sugars and for the blood pressure. I told her, let's give it 2-3 weeks. And she came back. We did an early glucose test so I saw her at 8 weeks and then again at 12 weeks. At 12 weeks, we did the early glucose test.
Why did you do that?
Because based on her hemoglobin A1C, I thought she was going to be potentially a pre-gestational diabetic. Potentially.
Yeah.
And she passed her glucose test. And I still told her to take some sugar logs, and she did, and they were good. And then her blood pressure, honestly, also was good, and it has been good.
Through exercise and lifestyle change. So the moral of the story is it's not too late, even in pregnancy, to make changes. It's not like you got pregnant and you weren't watching it, and now you're...
She was motivated. We came up with our plan, but she went and found her own dietitian. Yeah, she did not want to...
Yeah, there's also one thing for the client's head and heart being in it too, for sure. One more question about weight. Can a person gain 50 or 60 pounds in pregnancy and be healthy?
It's generally not healthy.
Why?
Extreme weight gain in pregnancy does have its own consequences. Higher chance of C-section, higher chance of babies having diabetes, higher chance of you getting diabetes, higher chance of you getting preeclampsia. Also, a much harder time going back to your pre-pregnancy weight. Let's say you gain 50 pounds and lose 30 of it, and then every pregnancy that's happening, it's hard. It's not healthy.
And then there's some research now that is pointing to how our pregnancy and our postpartum period was in relation to menopause too. Have you seen some of that
No,
research?
what do you mean?
Yeah, that people who never sort of get healthy after having babies and are depleted actually are known to have harder menopause
really?
also.
Oh,
Yeah.
interesting.
So the two is actually are now being put together because it's that you get depleted and then you never really recover.
Yeah.
Then you have another baby, maybe get more depleted, never really recover, go through your life sort of feeling like,
This is just
so-so with
normal, yeah.
anemia or low magnesium or whatever it is you're doing, excess weight.
Yeah.
And then we get to menopause and then everything then just becomes cross.
Yeah.
Like so
It's-
many confounders. You're like, which one is, am I tired? Did I do too much? Is it my period? Is it not getting my period? Was it the heavy period? What? There's so many things.
Yeah.
You know, and I mean, that's also how like people
And it
die,
makes
right?
logically it makes
It's
sense.
like, yeah, absolutely. So I love that research. I wanted to talk to you for a few minutes about when someone really should not exercise. When is it a scenario where it's like, I don't want you exercising, and what are the new obstetrical parameters on bed rest and the definition of bed rest and when it's needed?
Okay. So for the not exercising, there are some contraindications and relative contraindications. You don't want to exercise when your water's broken, when you're at high risk of having a preterm baby, for instance. Your cervix is very short, or you have a cerclagen, which is a stitch that closes the cervix so it doesn't continue opening. Some questionable ones right now that are in the guidelines but are being refuted are severe anemia,
Which is a hemoglobin of
probably under 8.
under 8.
Severe. We're talking
Oh my
about
gosh,
severe
that person
anemia.
can't even get out of bed.
Twins, it is on the list of contraindications. Again, that one's being refuted as well, yes, because of their high risk of water breaking early and preterm.
Oh, fascinating.
Talk to your medical professional.
Provider. Yeah, we're not giving medical advice.
Yeah, talk to your
Listen
medical
the-
professional. Even with twins, I still would advocate a little bit of exercise.
Right? You almost need more
Yeah,
stamina
I
and
know.
more strength to
I
be
know.
able to do that work.
Preeclampsia with severe features due to the increased risk of stroke, high blood pressure. It is also a contraindication to working out. And then things like placenta previa, when the placenta is blocking the cervix, or anything that has a high risk of an obstetrical complication.
Got it. And are we moving away from complete bed rest?
Yeah. Right now, there's very few indications for complete bed rest. You know, one would potentially be very short cervix or dilated cervix. Even then, complete bed rest is still not recommended. We do modified bed rest now.
Which means what? What's the difference between the two?
Back when they used to prescribe complete bed rest,
Yeah, like people in wheelchairs, right?
Women were not getting out of the bed or walking at all.
Right.
If they would get out, they would sit in a wheelchair and be wheeled.
The trauma of
They used to actually advise patients to lay in bed with the bed tilted up so their head is back and their legs are up.
No.
Yeah, that's what some of my attendings would tell me in residency.
There was a time where they used to x-ray pelvises in pregnancy and say someone had an inadequate pelvis
just
based
from
on
that,
the x-ray.
yeah.
And then the babies got burned from the x-rays. So, and then we had like,
People
all the
smoking,
medications and smoking. So it really is a practice. So what's modified bed rest?
Where you do walk around the house, you do your household chores, you are mobile, because if you lay in bed and are immobile, your muscles actually start decreasing in mass within 2 weeks, very quickly.
Yeah.
And then if you're on bed rest for months, it makes it very difficult towards the end of pregnancy. Your pelvis starts hurting. It's harder to push. Your just energy levels aren't there. So modified bed rest is you can still walk around. You can still do your daily chores, but no lifting. Try not to go up and down stairs. Try not to go, walk your golden retriever who can pull, or you have to run after. But definitely get up and walk around and be somewhat active.
And no intercourse with either modified nor complete.
That's called pelvic rest. Definitely in all those scenarios, we recommend pelvic rest for sure.
Okay, so pelvic rest is a part of modified bed
Correct.
rest. Do you need bed rest if you have a subchorionic hemorrhage? And what is a subchorionic hemorrhage?
I do recommend modified bed rest and pelvic rest for
Mm-hmm.
subchorionic hemorrhage. It's when there's a bleed behind the placenta.
And it can happen at any point in pregnancy?
It can usually happens earlier in the
Earlier.
pregnancy, and it does increase chances of miscarriage. I don't think the evidence is so strong that full bed rest will lower the chance of it. So that's why I think modified bed rest is a logical approach.
Mm-hmm.
You don't want to do things that are too stressful, where you're lifting heavy objects or doing weight training or anything that'll severely increase the intra-abdominal pressure. We also don't want to go to the other extreme and go on full bed rest, because that's also
psychological
exactly
ramifications too.
So the
right?
modified bed rest, I think, is the best approach until because the subchorionic hemorrhages or hematomas, they do usually resolve.
They usually resolve if it doesn't end in a miscarriage.
Exactly, and you want to try and reduce that and not cause anything that could probably perpetuate or propel that.
Love. Okay, as we're ending, I'm gonna tell you 3 things that I've learned from doctors.
Okay.
Then I want you to tell me 3 things that you've learned from working with midwives.
Okay.
Okay. I've got like 4,000 things that I've learned from doctors, but watching them suture, you guys do so much more suturing than we do. And so watching you suture, it's an art and a craft and a practice. So I'm always watching doctors suture because I learn techniques from you. Number 2, I have learned management of like weird gallbladder issues with doctors, including that medication that's called ursodiol. And number 3, I've really watched doctors react to external fetal monitors with a lot of patience and a lot of grace. So I've seen residents get like hyped up and then doctors be like, give it a second. Mm-hmm. Right? And so as a midwife, when I now hear something strange on the Doppler, I get an uptick in adrenaline, but I also have that little voice from that OB I watched do that was like, give it a second. Like, not only babies have reserves, but you don't need to actually like get all hyped up because of what you're seeing or what you're hearing. Listen a little closer.
So one of mine would be, I think doctors learn that from midwives. That's what
I learned.
Tell me
more.
That we also had midwives in our residency program, and part of the time we would be in the room with them or follow them, and as residents, yes, you do react a little bit more.
Yes, lots of book knowledge. Yeah,
I admit to, because exactly we're learning from books still. It's not real world medicine yet.
Correct.
And as residents, you're seeing a whole spectrum of things, because you're seeing every attending's patient. You're not, as an attending, you're only seeing your patient. As a resident, you're seeing every attending's patient and every attending scenario. So you think this is very common, but truly, for one private practitioner, this event is not so common. So they tend to be overreactive when they say, "But I just saw this last week. That's why I wanted to do this." Mm-hmm. And I would say, I understand. I'm aware of it, but this is not a common thing. I know you just saw it, but it's on my mind. I'm looking out for it, and I appreciate that you thought about it. But we don't have to do this yet.
Right.
We can wait a little bit. So I do think the patience on the tracings that doctors have, some of it is attributed to the midwives, because I think midwives are more patient with that.
Love that.
The second thing...
So that means we learn from each other.
Yes. The second thing I learned is just how much talking and encouragement, how much that can do for a patient. With the pushing effort, with the length of time the labor takes, some people expect you go in 12 hours later, you're going to have a baby. But, sometimes it takes 24 hours, 48 hours. Just talking to them, encouraging them, you're doing so good. This is your first pregnancy. It's not going to take long. Even the pushing, encouraging them, they don't know what's going on. They don't know how far baby's coming down. And the baby does come down very, very, very slowly. Yeah. And sometimes they think that they're not pushing well, or they're not, doing the right thing, or they're blaming themselves. Just the words of encouragement.
Self-doubt, yeah.
Yeah, definitely. I've seen midwives do that a lot, and I think it's very helpful. The last thing, different positions.
For OP, pushing or
for
labor.
For OP babies, for pushing.
Yeah.
How different positions work.
Yep.
Turning the baby.
Love.
Yeah.
All of that. It makes a difference.
Huge. Yeah.
Really.
Huge.
And doulas, right? We learn from doulas.
Yeah,
too.
100%.
We learn for women
I always,
to learn.
when I have a patient that says I have a doula, I'm like, all right, bring her to the labor room.
I love that.
Yeah, bring her in.
I love that. In closing, what do you wish that every birthing woman would know?
You're not in this alone, especially for your first one. You have our support. You have the midwife support. You have the doula support. You have all Mama Tusa with all of her information. Amazing resource. Listen to her podcast. Call her. Sign up with her.
All about me all the time.
But honestly, no, these little things, these little classes, even monthly words of encouragement and learning does wonders for a pregnancy.
Love. Amen. Thank you so much.
Thank you
It was
so much.
good to have you on. Thanks for your time. Thank you for caring. And it's really been an honor to have you on.
My pleasure. Thank you.
Mama Tusa is hosted by me, Atusa Benji, and produced and edited by Josh Stretton Carlson. Our theme music is composed by Mehri Lalazarian. If you'd like to support the show, please follow and review us on Spotify and Apple, or subscribe and like us on YouTube. This show is for informational purposes only and is not intended to be medical advice. Always consult with your healthcare provider when making medical decisions. See you next Tuesday.